All right, looks like we have about 40 people almost here logging in. So we're going to go ahead and get started. I want to thank everyone for joining us this evening for the Prostate Conditions Education Council's educational series. Tonight, we are joined by Dr. Brown, who graduated from the University of Illinois College of Medicine. He spent more than 20 years working with patients as a board certified urologist and is driven by the promise of improving the lives of men living with prostate cancer. He bridged the gap between community medical practice to a leading medical strategy for pharmaceutical companies and is currently a member of Dendreon's executive committee. Here, he's responsible for leading the medical organization, which includes not only research and manufacturing, but medical affairs and regulatory affairs. Dendreon developed the first immunotherapy for prostate cancer named Provenge. So we're very thankful to have Dr. Brown join us tonight to share with us information on immunotherapy. If you have questions, many of you have submitted them prior to the call, but if they're not answered during Dr. Brown's presentation, we will answer them after, and you can continue to use the Q&A function and the other avenues via email and texting if you would like to ask questions during the talk as well. Thank you so much, Dr. Brown. With that, I'm going to mute and turn it over to you.
Hi there. Thank you, Wendy. Good to hear from you again, and thanks for everyone joining today. I know it's a little unusual this year as we can't see each other or be in the same room, but I'm happy to be here. I'm Dr. Bruce Brown. I am the Chief Medical Officer of Dendreon Pharmaceuticals, LLC. Dendreon is in the advanced prostate cancer space, and we're going to give you a little bit of an overview and then really talk about some data that we presented recently, some of the newer things that we're doing. I know for some of you, maybe Dendreon is new to you, and for others, you maybe know the company better than me. So I'm sure we have a mix. So let's go ahead and get started, and then we'll have some time for questions. So Dendreon, as you know, I'll be honest, there's been some turbulent times over the years. Provenge, our drug, was approved in 2010, and there was great expectations of the expansion and uptake of Provenge. For various reasons, that didn't happen in the early years of Dendreon. And I think as some of you who followed Dendreon know, the company did go bankrupt in 2014. However, in 2015, it was brought out of bankruptcy and really turned around. And then actually, it is now a private company. And we have a relatively new CEO, Jason O'Neill. He started in June of this year. He is a veteran of the prostate cancer space, most notably at Sanofi, and he's been a good addition. So perhaps when we're able to gather, you guys might meet him at some type of advocacy meeting in the future. So again, we're going to talk about metastatic castrate-resistant prostate cancer. That is our labeled indication. Provenge is our marketed drug. The chemical name is Ciplucel T. It was the first FDA-approved autologous cellular immunotherapy, and I'm going to show you some pictures that describe it, because obviously this is different. We use the patient's own cells, and it's not like a pill you take or some drug that the pharmacist takes from the supply room and hangs. It's designed to induce an immune response, target against PAP, which is prostatic acid phosphatase, and that is an antigen that's expressed on most prostate cancer. A very, very high number of prostate cancers express prostatic acid phosphatase. Our indication is metastatic castrate-resistant prostate cancer, and of those patients, it's the ones who are asymptomatic, meaning they have no pain, or minimally symptomatic, meaning the pain is controlled by medications other than. So we kind of glossed over metastatic castration-resistant prostate cancer, mCRPC. So what is castration-resistant prostate cancer? Well, that's prostate cancer that progresses either clinically, radiographically, or biochemically, despite androgen deprivation therapy and the level of testosterone being at a very low level called a castrate level. Now, as you probably know, castration for a man means removal of the testicles, and that's where testosterone is predominantly produced. So removal of the testicles is one way to bring the testosterone level down to very, very low levels. Over the last, say, 30 to 40 years, or even more, but over the last 30 or 40 years, some newer agents to do that chemically have been developed that are really widespread and have really been the standard of care instead of the surgical castration. So if you look at this little box here, we're talking about disease progression. And when we talked about the types of progression clinically, that means just clinically the patient is doing worse, way less energy, not eating, losing weight. Radiographically, that means the patient's doing worse on the scans. So CAT scan, MRI, bone scan, even sometimes now PET scan, either the lesions are getting bigger or there's more lesions. Biochemically, that would be the PSA going up. And any of these that happen while the patient is on androgen deprivation therapy with low levels of testosterone, that defines castration resistance. And if that happens when the patient has metastases, that's when you get this metastatic castrate or castration-resistant prostate cancer. Sometimes you can get CRPC, castration resistance, without having metastatic disease. So obviously there's no progression on the scans, there's no metastatic disease, but perhaps clinically the patient is doing worse, or the lab-wise, the PSA is going up. So that's why it's CRPC. And basically, it's pretty easy to remember. C is for castrate, the testosterone levels below 50. R is for resistant. So the disease is resistant to the act of castration. It's progressing despite the testosterone level being low. And PC, prostate cancer. So that's kind of an easy way to remember it. All you really have to know is the CR, the PC, you know it's prostate cancer. And if there's an M in front of it, it's metastatic. NM means non-metastatic. Sometimes you'll see it called M0, which means no metastatic disease. And then this would be called M1. But usually it's just called MCRPC or M. This is an overview of Cipla-Cel-T of Provenge. And again, it's a paradigm shift from any medication that came before it, which was a good thing and a bad thing for us in retrospect. It was a good thing because obviously it's something novel for patients that helps them use their own immune system to fight prostate cancer. But it was maybe a bad thing, to be quite honest, because it was so different. Everyone was used to pills or chemotherapy, and they had a hard time getting their hands around this or their head around this at the beginning to really understand. Anyways, you have a prostate cancer patient, and leukocytes, which are white blood cells, a type of blood cell that fights infection and cancer, are harvested from the patient. Now, that sounds a little bit morbid, but actually they're hooked up to a machine that collects their blood, filters out the cells, and then gives the blood back to the patient. A little bit like dialysis, where your blood volume is running through this machine. In dialysis, it's to remove the harmful toxins because your kidneys are not working. In this, it's to remove a very small percentage of these leukocytes. And it's such a low percentage that it would not affect anyone by not having them. They get regenerated quickly. So these cells are harvested, and then through some chemical means at our manufacturing facility, successive steps called density gradient centrifugation, we come up with the exact cells that we want, the peripheral blood mononuclear cells, PBMC. And part of the PBMC population is the APC, called antigen presenting cells. Antigens are foreign proteins, or think of them as toxins, and the antigen presenting cells take them up and then present them to other cells of the immune system to hopefully get rid of them. One type of antigen presenting cell is a dendritic cell, hence our name, Dendreon. Anyways, you have these PBMCs after they've been separated out, and they're cultured. They're put in, kind of a vat, a liquid or container with this protein that we make with a partner. We call it our fusion protein, but it's made up of PAP. Remember, we talked about it. That's on the prostate cancer cells, and that's going to be our target. It's this recombinant product of PAP fused with an immune stimulate, GM-CSF, granulocyte macrophage colony stimulating factor. These are fused together. They're cultured with the cells, and once that culture is done, you get our drug. It's called Provenge, Ciplasol-T. It's the activated antigen presenting cells that display these PAP peptides. So they've incorporated the target that also has this immune stimulant, and these cells are going to be given back to the patient to go fight the cancer. This is just another overview. So on day one, the cell collection happens. Takes about 3 hours. And then that's immediately shipped to one of our manufacturing facilities. We have 2 facilities, one in Orange County, California, and one outside Atlanta, Georgia. Over a 2 to 3 day process, the cells are made into Provenge. So what I just talked about on the prior slide. And then the Provenge, the cells plus the protein, fusion protein, are shipped back to either the doctor's office or the hospital. And the drug is infused with just a simple IV. Patients usually get some pre-medication before. The drug's infused about over an hour, and then they're watched for about 30 minutes after. So maybe about 2 hours of their time, minus commuting. And that's it. You do this whole process 3 times, and that's all the Provenge you need. Another way to look at it is, again, these cells are collected. This is the cell we're looking for. It's separated out right here, and then it's cultured with the fusion protein, and you see it starts displaying this target on it and starts changing, and it changes into this kind of, I'm sorry again. I think I never gave a talk here. It's changed into this angry fighting machine of a cell with these spikes on it that targets the PAP, the target of prostate cancer. It's given back to the patient, and these cells that we've already changed a bit start imposing their will, so to speak, on the other normal white blood cells in the body to make them angry and go fight the cancer too. And what it does is it stimulates the T cells to recognize this target, and they go to the tumor, recognize the target, and attack. Wendy, do you want to take questions now after this section, or do you want to wait till the end?
Let's wait till the end.
Okay, very good. So our drug got approved in 2010 and by the FDA, which was a whole saga in itself. But anyhow, we got approved. Saga because there was a lot of politics going on and some competing issues, but the story for another time. So when the FDA approved us, they said, fine, your drug's approved, great, give it to patients. But we thought we saw maybe an issue with your safety in the trials that you submitted to us. And we're worried maybe there's an issue with cerebrovascular events, varieties of stroke. So we're going to approve you, but we're telling you, we're mandating that you have to do a safety study for a couple of years and just prove that this cerebrovascular issue is really not an issue. So of course we said okay, because we had no other choice. This was a large observational trial. We call it a registry. It started recruiting patients in 2011. It finished recruiting them in 2014. and then each patient was followed for at least 3 years. So the study started recruiting in 2011, and it finished the follow-up in 2017. The primary endpoint, so that's our main goal in doing the study, what we want to really find out about, was to quantify the risk of these cerebrovascular events. And we compared it to historical controls of similar men with prostate cancer, but who did not receive our drug. We also added on secondarily to look at the overall survival, which is pretty easy, quantitate how long these patients live. And then we looked at some other things, timing and sequence of other anti-cancer agents. Now this was a registry, so we just recorded what the doctors did. We didn't tell them what to do. So if the doctor wanted to, tell the patient to eat tomatoes and bananas, we recorded that. We didn't tell them that, hey, that's nuts. It was really dictated by their decision, of course, with the patient's input. This is a curve showing the survival of the patients in PROCEED. And on the y-axis is the probability of surviving. So 100% everyone's alive, 0% everyone's dead. And on the x-axis, the time from the first infusion of our drug, Cipla-LT. And the median, so half above, half below, median survival was almost 31 months, which was, we thought it was good. Now there's no group that did not get Provenge, so everybody got Provenge. But just to give you some reference, in the pivotal trial, the trial we used to get our approval, the survival with our drug was 25.8 months. So it was lower. And these patients were caught a little bit earlier in the spectrum based on their PSA. But the other thing is, when you do a registry like this, you basically take all comers. We just said all you have to do to get in is get our drug. Whereas in a clinical trial, a lot of patients are excluded for being too sick or having certain characteristics. So we felt happy with this, and we felt that it validated patients living for a fairly long time with pretty bad disease. One of the things we did in our trials to get approval is we analyzed the data even further and found that men who started our drug with a lower PSA actually lived longer. Not only did they live longer, the difference between the treated patients and the control patients was even greater the earlier they started, so the lower their PSA. And that was one thing that really helped us, convince some doctors and patients that our drug was good and to get it in earlier in this MCRPC space. So we did a similar analysis with the registry, and the registry I'm talking about is called PROCEED, PROCEED. And we took the PSA values when they got our drug and divided it into 4 groups. And the same thing happened. The group with the lowest PSA lived the longest, almost 4 years. Keep in mind, before all these drugs were developed, these patients used to live about 18 to 24 months. So this is pretty good. As the PSA got higher, the survival got lower, which makes sense because the higher the PSA, generally, the more disease they have. So that was one thing, we saw, first of all, we saw our drug was safe. When we compared the risk of cerebrovascular events to the control group, there was no difference. So we answered the FDA's primary question. And then we showed that these patients lived almost 31 months and also confirmed, like we showed in prior trials, that the earlier you start Provenge, in our labeled indication, the longer you live. So the premium on getting it in earlier meaning lower PSA. Now we did another sub-analysis of this PROCEED data, and let me backtrack a little to tell you why we were interested in this. We did 3 phase 3 trials prior to our approval. And unfortunately, for us and for patients, we had very few African Americans in those trials, which is common in medical trials. However, we did find that the African Americans who got our drug seemed to survive even longer than the white men who got our drug. But again, it was very small numbers. But PROCEED, remember, is 1,900 patients. And we enrolled a lot of African Americans, about 12% in this trial. So we had over 200 African Americans. And we wanted to restudy that because, first of all, it was interesting. It was potentially very impactful for African Americans. And it was contrary to pretty much anything else that had gone on in cancer. There's not one cancer treatment prior to this that showed that African Americans do better than whites. It's most always the opposite. They do worse. So what we did is we took a group of African Americans and Caucasians and we matched them to try and make sure they were similar groups. And the thing we matched them with was their PSA when they got Provenge. We took all of them, 219 African Americans, 438 or 2x Caucasians, and we looked at their survival, and we saw the same thing that we saw in those earlier trials, that the survival difference between blacks and whites was 9.5 months, favoring the black men. And another way to talk about that statistically is there was a 30% reduction in the risk of death in black men versus white men. We broke it down even further. Of this group, so we have these big groups that are matched by their PSA. We took the median, below the median PSA for those matched groups and above the median PSA for the matched groups. And we looked at the survival difference there. So as you can see, below the median of 29.48, and I will just say, in current practice, most everyone is caught before a median of 29.48, and they're started on some treatment, whether it's Provenge or the oral agents or chemo. There was an even bigger survival advantage for syphilis LT in the African American men. It was almost 21 months, 20.9 months, increased survival for black men versus white men. White men was still pretty good, 33 months. Black men was 4.5 years. Now, when you took the higher PSA, the patients with more disease burden, there was still a difference between the groups, about 5 months, but not as marked. If you look at a lot of trial data, this is really remarkable the way these curves separate, and there's so much of a difference between the two groups. And I'll be honest with you, I'll tell you a little story. When I had first started with the company, I've been with the company 3 years now. The first time I presented this, I wasn't that familiar with it. And I started presenting this slide and I sort of stopped and I said to the audience, I said, I'm sorry, this slide is clearly wrong. There's no way there could be that difference. So I'm really gonna ream out whoever made this slide because they made a big error. Well, I was the one who made the big error. This is the survival difference. It's humongous. So again, that's our registry, which completed in 2017, was done to answer the question the FDA had potentially about safety, which turned out not to be an issue. Looked at our survival, looked at the survival increasing when you start the drug at a lower PSA, and also confirmed this thought we had that African Americans do better than whites when they take our drug. The next obvious question is, why do they do better? And I don't have an obvious answer. There's multiple hypotheses. We're studying them now, as well as other groups. Some people think that the tumors are different between African Americans and blacks, that the African Americans tumors may be driven by more immune pathways, hence they respond better to immunotherapy. Some people think it has to do with the immune system itself in an African American patient. There are issues about access with African Americans versus Caucasians, although all these patients had access to our drugs. So those don't come into play in our results, but it's certainly an issue in the real world. But again, that's future studies. Hopefully someone will have a good answer for that in the near future. So in my 3 years here, one of the things we kept hearing from doctors is, there's 6 approved drugs in metastatic castration-resistant prostate cancer. And most of the patients are going to get more than one of the drugs. Why do we need to give them Provenge? It's different, right? Remember, you have to do the blood collection 3 times and come in for 3 infusions. You know, it's different. It's a bit of a burden for the patient. They have to come in 6 times in a 4 or 5 week period because the treatments are spaced 2 weeks apart for the most part. You know, they have to get the blood collection, they have to come in and get an IV infusion. You know, maybe it'd be easier if we just mailed them the pills. So can you give us some reason why we need Provenge? That was kind of the data gap that we were faced with. So what we did is we looked at some real world evidence, and I'll show it to you in a minute, showing that adding Provenge to the advanced prostate cancer treatment regimens prolongs over a median survival by 14.5 months. And I'll show you how we did this. This is a press release when we published this article. So this is the study, effectiveness of Ciplas-LT and overall survival in Medicare beneficiaries treated for advanced prostate cancer. A lot of words. This was our research question. Among Medicare beneficiaries, that's the data that we got, was patients on Medicare, and it's Medicare A, B, and D, not Medicare C. Among those patients with advanced prostate cancer, what is the comparative effectiveness of Ciplas-LT? And we compared it to the oral agents, which are abiraterone and enzalutamide. What is the comparative effectiveness on overall survival with 3 years of follow-up? So what we did to find appropriate patients is we got access to this Medicare database through a vendor. We started with 40 million, that's right, 40 million male Medicare beneficiaries, and 452,000 had a prostate cancer diagnosis. Of those, 6,800 received a treatment for mCRPC. So either our drug, the oral agents we just talked about, or chemotherapy. So this 6,800 was our treatment group of interest. So we basically had 2 analyses. One was we compared first-line use of Ciplas-LT with first-line use of the orals. So one group got Ciplas-LT first, one group got the oral agents first. But then you could get anything else, second or third or fourth. The other group was patients who received Ciplas-LT versus those who received orals but never received Ciplas-LT. So this is even simpler. Somewhere in the regimen, they received Ciplas-LT, versus those who in their regimen never received Ciplas-LT. First, second, third, 20th, whatever. Actually, we only looked to about third or fourth line of treatment. And then we also, in an exploratory fashion, which means not as rigorous on the statistics, did look at the sequence of Ciplas. So again, I told you these were Medicare patients, parts A, B, and D, that started their first drug for mCRPC in 2014, and we followed patients 2015, 16, and 17. So all those patients from all those years. This is just more about our statistical methods and the groups, which I just described the groups. We also looked at other variables besides their survival. We looked at their age, we looked at their race, we looked at their eligibility. That would be if they had Medicare and Medicaid. We looked at this thing called the Charlson Comorbidity Index. It's kind of a measure of how sick you are with other medical issues. We looked at the metastases. Were they in lung, liver, brain? Were they in bone? Were they in lymph nodes? We looked at different lines of therapy for mCRPC. We looked at the time to the second therapy. We looked at prior skeletal related events. That's what SRE stands for. We looked at opioid use, and we looked at steroid use, because all these could have been confounders and could have had a harmful effect on the overall survival. And if we didn't factor these in, we may not have known it and might have come up with the wrong conclusion. All right, this is kind of a busy slide. But let's look at this. And it's basically one analysis is on the left, one analysis on the right. The univariate just looks at the survival, and the multivariate factors in all these other variables to really see if the the thing we're studying, which is the different treatments, is a true result. So the univariate obviously is quicker, and we found that if you give Cipla-Cel-T first versus an oral cancer agent first, the survival was much longer with Cipla-Cel-T, highly statistically significant, I think about 14 months, big separation between the curves. And when we looked at the other cohort, which was if you got Cipla-Cel-T and whatever, or just whatever, and never got Cipla-Cel-T, same almost 14-month survival advantage. So if you got Cipla-Cel-T and whatever else, you lived 14 months longer than if you got whatever else, but never got Cipla. Then we did our more detailed and more truer, if there's a word, multivariate analysis to make sure we didn't have any confounding variables that affected these results. And lo and behold, we got pretty much exactly the same thing. So this was a true finding that if you got Cipla-Cel-T first, you live much longer than if you got it after first, second, third, fourth. And same thing here, if you got Cipla-Cel-T and whatever else, or you got whatever else, but no Cipla-Cel-T, you live much longer if you got Cipla-Cel-T. Again, about 14 and a half month difference. So again, just to go back, because I have the exact numbers, this difference is 13.9 months favoring getting Cipla-Cel-T first, and this difference is 14 and a half months favoring getting Cipla-Cel-T versus not getting. For all you statistics aficionados, this is highly statistically significant. Almost a 40%, over a 40% reduction in the risk of death. In the cancer world, that's huge. Huge. Drugs get approved if there's a 15 to 20% reduction in the risk of death. This is almost 50% reduction. It's over 40, 44 and 41%. So what are the conclusions from this? Men receiving Cipla-Cel-T experience longer OS compared to those receiving the oral agents, either in the first spot or just getting it versus not getting it. These findings support some of the guidelines recommendations. There is an ongoing need to figure out the best sequence, because now that you have 6 drugs, there's a, you can do all the permutations of that. There's a lot of sequences, and nobody's really studied that. So in our future research, we're going to look at the different ways to sequence it. Now, I should tell you, there are limitations of this type of research. Basically, the data for this research was, in the old days, when you get a super bill at the doctor's office. So when you go to check out, the doctor or nurse would have circled what visit you had, what procedure, and put in the diagnosis and any tests that might have been done. So it doesn't take into account a lot of clinical data that you would see actually reading a chart or reading the X-ray results, closely. So this really didn't take into account the patient's PSA. And that's a limitation of all this type of research called claims research. However, we had huge numbers and we did control for some confounding variables. So we felt like we took some measures to make sure that the groups were fairly similar. But it is a reasonable objection or limitation to this. Again, we touched on this. We're gonna do more studies and look at the sequencing and the layering. Sequencing is using them the medications one after another. Layering is usually 2 at one time or 2 within a short period. So we're gonna, because different doctors do it differently, and there's no data on which is best. So we are gonna look at that too in our second round of studies of this data set. I want to tell you just about an exciting study that's underway. This is called the PROVENT study. If you think that's a good name, give me credit. I thought of it. If not, I'll pass it off on someone else. But this is an interesting study. So this is basically taking our drug, Cipla-Cel-T, and studying it much early in the prostate cancer journey. We're studying it in patients who are recently diagnosed with localized disease. For those who know the Gleason numbers, the Gleason scores, it's Gleason 6 and Gleason 7 patients, some of the Gleason 7. No metastatic disease. These are patients who might be deciding between active surveillance radical prostatectomy, or radiation therapy. So for those who are inclined to do active surveillance, we're doing a trial where 2/3 of them get syphilis LT, 3 infusions over 4 to 5 weeks, and 1/3 of them don't get syphilis LT. And we're following them for up to 3 years. And the main determinant of our primary endpoint is the subsequent biopsy, and basically to see if the biopsies get worse. So if the Gleason 6 patients go to Gleason 7, or if the Gleason 7 patients go to Gleason 8. We've fully enrolled the trial. There was quite a bit of enthusiasm. Fully enrolled 6 months ahead of schedule. Now we're in the follow-up phase. Patients get a biopsy at 12 to 18 months, and then at about 36 months. So we'll have some answers in a couple of years. This would be huge. This would be very practice changing if we found that our drug was effective in reducing the progression of these early patients, because then they could forego having to have a radical prostatectomy or radiation therapy, which have potentially life-altering side effects. Okay, so Wendy, I am done. You told me 30 to 40 minutes, and I'm happy to answer questions or talk about what anyone would like.
That's wonderful. You did a great job. Thank you so much. So we have kind of a long list of questions here, and I think you kind of answered a few of them as you went through. So I'm going to still kind of include some of those because maybe you can expand on them a little bit.
Sure.
The first one I'm going to go with is you did mention layering and sequencing. One of the questions is, can you use Provenge with other treatments like hormone therapy? Do you want to talk a little bit about that specifically?
Yes, so hormone therapy, the answer is yes. Hormone therapy is really the backbone of advanced prostate cancer treatment, and hormone therapy is also known as androgen deprivation therapy, or ADT. So I'll try not to make anyone dizzy, but sorry. So when patients progress with prostate cancer, that doesn't have to be metastatic disease. Common scenarios, you had a radiation or surgery, PSA went down very low for a while, but now it starts coming up. You do your scans, there's no cancer, but you know something's going on because your PSA is going up. Often they'll be put on hormonal therapy or ADT. And again, that's the surgical castration, or more commonly the chemical castration, to bring the testosterone level way down. Because testosterone is the food for prostate cancer. So if you take away the food, things don't grow. So that hormonal therapy is usually kept in place for the rest of the patient's life. And often these treatments I alluded to are treatments, syphilis LT, Provenge, the oral agents, abiraterone and enzalutamide, they are all put on top of the hormone.
Perfect. Here's another question. Is anyone eligible for Provenge? So I know like right now it's advanced disease, but do you want to talk about if anybody may not be eligible to receive Provenge?
So yeah, our label indication is a bit narrow, but it's in this MCRPC spot. Metastatic, the bones, lymph nodes, lung, mainly to the bones, over 80%, or it could be lymph node or soft tissue. Metastatic CRPC. So you've been on the hormone treatment, but you failed, you keep progressing. So of those patients, the ones who don't have much pain, no pain or minimal pain, those patients are all eligible for Provenge. I'm not on the commercial side, but I could tell you it's quite well covered by the Medicare and the insurance carriers. Those are the patients who are eligible, and it's indicated, and that's what's denoted in our label, you know, the package insert. For those who maybe have advanced disease but don't quite reach that threshold, it's not our labeled indication, so be considered off label. We can't try and sell it to that indication, and the insurance most always doesn't pay for it.
Yeah, there's a lot of questions coming in kind of similar to that. And so your Provent trial, and I do like the name, by the way, will be really interesting to help get it earlier. So we have probably 3 questions at least around earlier use of Provenge. So basically, the most recent question is if there's an advantage to starting immunotherapy, or I should say, is there an advantage to starting immunotherapy at the very earliest stage of an increasing trend of PSA after prostatectomy?
Yes, so we did some studies in years past. Honestly, I mean, I wasn't there at the company, but we didn't meet some of the endpoints. Now, one of the endpoints was PSA driven, and as some of you who know a lot about this, our drug does not affect the PSA, although it affects the overall survival. So we had PSA as an endpoint, didn't really reach that. So we never really showed a definite clinical advantage. However, from an immune point of view, we do know that the immune system reacts much stronger to the Provenge the earlier in the disease state. And that was part of the rationale for doing the Provenge trial, where it's very early. And it makes sense because what governs how well the immune system responds to immunotherapy? Because we're basically inducing the patient to use his own immune system to fight the drug. So if the patient has just horrible disease and is unfortunately about to expire, their immune system's not as strong as if you're 2 years before that. And also the less disease burden you have, the bigger the immune response. So we did have found that in some of our earlier trials. Unfortunately, either from design reasons or other reasons, we weren't able to correlate that with a clinical advantage, either being long-term survival or PSA response. So the answer is kind of no, officially no, but scientifically there's some evidence for it. But again, that's not enough to get the insurance company to pay for it.
Mm. So can you talk a little bit about, you just mentioned PSA response. So we have a question about how do you know if Provenge is working for you? And then another question that talks about how do you know when Provenge stops working?
Right, so that's a bit of a conundrum because like other treatments, you can't just follow the PSA. We know Provenge is working because the studies prove that it live longer. However, for just one patient getting it, nobody has a crystal ball to say when you would have passed away had you not gotten the Provenge. So the doctors use different methods. They know the PSA is going to go up. Oftentimes it kind of goes up slowly, and they appropriately counsel the patient not to worry about that. We're not necessarily going to give you more treatment unless your scans maybe get a lot worse, or you start having symptoms, pain, reduced appetite, weight loss. PSA is an interesting thing because patients use that across, even when they don't have prostate cancer. Patients, often go in for their annual visit and get a PSA. And then if that doesn't look good, they might get a biopsy. And if the biopsy shows cancer, they get treatment and they follow the PSA. On and on and on. However, PSA has never definitively been proven to correlate with survival. And actually, if you wanted to do some kind of promotional, some advertising to patients and doctors, the FDA won't let you use PSA to convince them that the drug works. So again, PSA is kind of accepted, everybody uses it, but the FDA wouldn't let you use it in an official capacity to promote the drug. We found, and again, this was maybe a bit of a lesson learned, to be honest. When we rolled out our drug, immunotherapy was new. There weren't that many treatments for prostate cancer for a long time. And honestly, we didn't fully understand all the ways our drug works. But now we do. It takes a period of about 3 to 6 months to activate the immune system. And we know that because we've measured certain types of immune responses, types you do in a research lab. And we've looked at the time course and looked at the magnitude of those responses. So a whole bunch of different tests for that. We've done some models to kind of simulate cell killing, cells treated with Cipla T. And we've also sort of defined something called antigen spread. So remember, Our drug is directed against PAP, prostatic acid phosphatase. That's the antigen expressed in most prostate cancer. However, what happens after a tumor cell is killed, there's other antigens, other proteins, other targets in it. And as the cell gets killed or lysed, those other antigens are liberated into the bloodstream and recognized by the immune system. And it's a wonderful thing. The immune system starts mounting a response to them because it's a foreign thing. It shouldn't be there, like an infection or a cancer cell. So the immune system starts developing antibodies to them. And what we found is that, probably starting about 3 to 6 months after Provenge is given, not only are we seeing antibody response, which shows there's been an immune reaction against what we targeted, the PAP, there's antibody response and immune response against antigens we didn't target, but we know they're common cancer antigens. So that's another way that the Provenge works. But again, it's different. It takes longer because you have to recruit the immune system. It's not this quick kill where your PSA starts going down in 2 weeks. So it's a different to understand, and the physicians need to really counsel the patients because this is different than any other. I don't know if that answers the question, but
yeah, that's excellent. Okay, we have a few more, so I'm not going to let you go yet.
All right.
This
Drew
is
said I don't leave till Drew tells me I can leave.
okay. Well, we have Drew on lockdown, so he can't tell you to leave or not.
All right.
So this is a question I actually haven't thought about. Do genetic mutations impact how Provenge works?
So let's again take a step back. What leads to a cancer cell? It's a normal cell at one point in your life, and it turns cancerous. And what largely drives that is mutations. Things go awry in the cancer, and some of the normal things that a cell does to stay cancer-free break down because of these mutations in the genes, the instructions. The genes are the instructions for what the cell's going to do. They break down. Different cancers have different rates of mutations that would cause them. And actually what you see in some cancers, that the more mutations in that cancer, a lung cancer, a melanoma, a bladder cancer, the more receptive they are to immunotherapy. Not necessarily targeted immunotherapy like ours, but the immunotherapies you see on TV like Keytruda and Opdivo for lung cancer, melanoma. So that's called the tumor mutational burden, antigenicity, inflammation. It's all pointing to this rate of tumor mutations. Prostate cancer is on the lower end of that spectrum. You would not expect prostate cancer to respond so well to the garden variety non-personalized immunotherapy, and it doesn't. When you give the Keytruda in general or Opdivo to prostate cancer, generally you don't have a huge response in very select situations. Now, to answer your question more, yes. So prostate cancer, unfortunately, is only a decade or two behind some of the other cancers. There are 2 new drugs approved this year targeted towards specific mutations in cancer patients. It's a number of mutations, but the ones people know the most are the BRCA, BRCA1 and 2, which you see sometimes in prostate cancer, and you see them more in ovarian and breast cancer. And there's 2 drugs that have indications in those other cancers that are now approved in prostate cancer patients who have specific genetic mutations. Now that's great for those patients, but it's a small amount of patients, probably under 10%. But something to keep in mind, especially if you try one of the standard non-targeted treatments and then you still progress, hey, you should check the tumor or your blood and see if you have these mutations, and maybe there's some other options.
That's great. It was fascinating for me. I've never thought of that. So obviously here's one that we should talk about. What are the side effects of Provenge?
Okay, very good question. I probably should have covered it. Side effects are minimal. So if you think of Provenge, what is it actually? It's over 50 million of these stimulated cells basically in a bag of lactated ringers, which is the standard IV solution. Not a whole bag, it's 250 cc's, so about a little over 8 ounces. The cells are a very small portion. But if you think of a typical infusion reaction, when something a little bit foreign is being introduced to your body, it stimulates the immune system. You can get some fevers and chills and some pain because your immune system's ramping up. It's releasing some substances called cytokines, like when you're fighting the flu type of thing. Those side effects are common, but they're usually mild to moderate. Almost always can be managed at home, maybe with just some over-the-counter things, and they most always go away within 1 to 2 days. You have it more on the second and third infusions. Once you get through that, there's no long-term side effects of the Provenge, because again, it's just stimulating your immune system. It's not going to do anything long-term like some other drugs where we find out there's long-term problems with.
Thank you. And then here's a question on, do you only get Provenge one time? So I believe this is going to be a booster question.
Yes. So yes, we're only indicated for the one course, which is the 3 treatments 2 weeks apart. We do have some data that shows patients who get a booster treatment, it does really boost the immune system, and some of those immune assays that we measure have even higher readings after the booster. But it's not in our label. We don't have clinical data that shows having that immune boost after a booster dose leads to longer survival. Practically, the insurance companies almost always will not pay for it, from what I hear. That being said, I could certainly tell you, we're amongst friends. We don't keep track of it, but we know some patients just pay out of pocket and get a booster every once in a while. I'm not recommending or promoting that, but it certainly has happened. I often hear about it at some events like this when we're in person and someone comes up at the end, either a doctor or patient, knowing of that situation. But it's not widespread. And again, it's of course very expensive.
Yeah. Thank you. Can you still enroll in the Provent trial?
No, unfortunately, the enrollment's closed, and we're in the 3-year sort of follow-up phase.
So now we have to wait.
Yes.
And then here's another question. Very knowledgeable. What is the best scan to find a metastatic lesion early?
Well, so traditionally it was CAT scan and bone scan. PET scan has been great for a lot of cancers. The run-of-the-mill PET scan has not been great for the run-of-the-mill prostate cancer. It has to do with the tracer agent that's used and some obstruction by the urine produced by the kidneys and in the bladder. However, in the last several years, there's a different type of a metabolic scan called an Axumin scan that is more sensitive than the traditional bone scan and CAT scan. There was another type of sort of bone scanning. It was a sodium fluoride PET scan that was good for picking up bone metastases, which was approved. However, of late, I believe that Medicare is not reimbursing for that. So you have your Axumin, the company's called Blue Earth. And then just always around the corner, they were talking about a PET scan targeted to PSMA, which is kind of similar to PSA and PET, expressed on prostate cancer cells. Multiple companies are developing this PSMA PET scan, and one was actually approved today or yesterday. So, I think the data would show that's the most sensitive. Now, currently, it's not available in a widespread fashion. I think it's actually only available at 2 medical centers in California. And I'm just from some competitive intelligence we're gathering, I think it's going to start to be reimbursed in January. So around the bend, I would say these new kind of PET scans, PSMA PET scans, are going to be the best. And the one that's been out several years, the Axumin, which is specifically is also better than the traditional bone scan and CAT scan. Another long answer.
Yeah, that's great. It is a frustrating thing because a lot of these new scans are hard to come by,
Yeah,
especially in
so there's
areas like where I'm
one
at. Yeah.
other, yeah, I'm sorry to interrupt. There's one other that was approved some years ago, the choline PET scan, but that's also not widely available. And the radionuclide, the choline element, I think is very unstable. So you have to use it quite soon after it's kind of mixed or activated. So there's been some glimmers of hope, but not like for every patient at, in every locale, et cetera. Hopefully that will change in the next 1 to 2 years.
Yeah, we'll see. So I'm going to combine a couple of different questions here. And I don't know that there's necessarily an answer to them, but it's certainly worth a little bit of conversation. And it's, why don't all men get Provenge when they have advanced cancer? And part of this question came from a gentleman who's advanced, very advanced. And he wanted to know, is it too late to get Provenge once you've had chemotherapy?
No, it's not too late. Um, as long as you don't have narcotic dependent cancer pain and you're in that MCRPC space, you can get Provence. I mean, there's patients where I would guess it works better than others, but no, as long as you're in that asymptomatic or minimally symptomatic MCRPC space, anybody can get it. As to why doesn't everyone get it, I wish I knew. Um, and we wish we knew at Dendreon, of course. Every company would like every eligible patient to take their drug. Um, uh, you know, what have been some of the pitfalls? And look, Provenge has treated over 30,000 men. So it's a huge amount of men that have had their lives prolonged. Um, but I think, again, when we were approved in 2010, there was no immunotherapy. All these fancy the drugs that you see on the billboards, the Keytruda and the Opdivo, they weren't approved then. So doctors and patients weren't used to hearing about immunotherapy. It was a bit of a foreign concept. So we were the first, we blazed the trail. And, sometimes it's better not to be first because you learn a few lessons and you warm people up to the thought of immunotherapy.
Yeah, good point. So I was also going to just mention you, or my personal question is, maybe you could share a little bit about what are some of the challenges of being a first in class therapeutic? And you mentioned some of the financial struggles that come with that, but do you want to share any other areas that being the first kind of therapy on a market is tough?
Yeah, so it's tough. Like I alluded to, we're the first approved immunotherapy. We're a cellular immunotherapy. So doctors and patients weren't receptive to it and didn't understand it. All the other treatments, except chemo, the 2 or 3, if there's 4 oral pills now in advanced prostate cancer, and androgen deprivation therapy, they all either work to decrease the testosterone level or block the action of testosterone. That's a mechanism of action that's been used against prostate cancer for 50, 60 years. And actually, Dr. Charles Huggins was a urologist. He made that first discovery and he won a Nobel Prize in 1966 for it. So all the other treatments, they're great treatments. They're my competitors, but they're great treatments. They're all kind of some wrinkle on the testosterone. So all the oncologists, urologists, radiation oncologists who treat prostate cancer, they understand that pathway. But the immunotherapy was new. And again, when it came out in 2010, there weren't immunotherapies available for other types of cancer. So that was definitely a challenge. The other thing is, again, this is bad on us. We didn't have a full grasp of how our drug worked, so that we could educate the doctors and patients. Because it was new, we maybe could have done better if we had a fuller understanding of how it does work, being different.
Great comments and great answers. It is tough. And sadly, I was around way back then, and I do remember some of those challenges and struggles. But we're very thankful it's here now and available to people to access right away. So I want to thank you so much, Dr. Brown. We really appreciate your time and all of the information that you shared. It's very insightful. And I just want to make sure that anyone who joined a little bit late, or if you want to share this webinar with others, you're going to be able to access the recording on the prostateevents.org website. So thank you again, Dr. Brown. I can't tell you how much we appreciate your time.
Sure, thank you. And hopefully next time we'll be in person.
I hope so.
Hope everybody stays safe. Happy holidays.
Thank you. Have a great evening.
You too. Bye.